Okay, so thank you, Dr. Harsh, for inviting me to talk about this very important topic, is which perimeter to buy. Unfortunately, that decision is not such a simple decision, and usually this decision is taken by the administrators, and so it is a little complicated. So first of all, before you decide to come into the market, you have to know why you are buying a perimeter. So if you are an individual practitioner just having a small clinic, why do you need the perimeter? Are you just going to check patients and diagnose glaucoma and other conditions where there are defects in the visual field? Or you want to have significant number of glaucoma patients who need follow-up tests and progression analysis, and you are going to manage them in a very, very scientific manner. So the whole key comes on to these glaucoma patients who need progression analysis. So how is this actually done by the machines? So I am going to put it simply in the terms which an administrator can understand, not necessarily a glaucoma specialist. So what they do is they take a normal group of patients and who are tested, a group of say 100, 200 patients are tested, and mean deviation is calculated. And anything which is 2 standard deviations away from the mean which they have calculated, they will label as abnormal. So this is a statistical abnormal. Does the statistical abnormal carry on to glaucoma? Well, that is not that straightforward. And for many years, all perimeters used to do exactly this only. But then they have gone further and they have seen patients who have glaucoma which is stable, tested them repeatedly, and then calculated the variation and standard deviation of those patients at various points. And when this variation goes outside the range which is seen in the glaucoma patient, then there is given a p-value and a significant value. And therefore, the repeat tests are then compared to the baseline and previous follow-up visits to give you an event and a trend analysis. So this is what is being done for glaucoma patients. And this is the glaucoma progression analysis system. And it is similar in all the more advanced perimeters. The strength of the perimeter lies in the size of the database. So basically, perimetry, the testing hardware itself is not such a expensive or a fancy thing, but it is how you put it through the tests, calibrate it, and give the data, put in the data into the machine so that the analysis comes out more useful. So you have to have a wide range of data, including racial, and that should be replicated in the testing conditions in your clinic to get the similar outcome. So definitely machines which have been more extensively used and tested and the data has been put in definitely carry an edge. Then there is other hardware which goes into the machine, which makes the test more reliable. So there is fixation monitoring to make sure that the patient's eye is not roving here and there. There is gaze tracking, which also does that. And there are shorter test duration tests which are available, which are smart because they have used analysis and data to make this test go faster. So there is CETA faster, and TOPS, which is there in Octopus. And these tests are more intelligently designed using computer software to make the test time less. So I have made a practical classification called class 1 and class 2. This is my own classification. So it is not that it is being made by somebody. So class 1, what I call are perimeters which have a very large database, which includes racial specific data as well. They have specific glaucoma progression data from a very big database of glaucoma patients, stable glaucoma patients, and has very good standardization. In addition, has short testing time strategies. The class 2 perimeters are the ones which have relatively small numbers. Many times, if you ask the question, when you go to buy the perimeter and ask them, what is the size of your database? How many patients were tested? Where they were tested? What was the classification? Were they glaucoma patients, normal patients, or general patients? They are not able to give you that data. When they are not able to answer your question reliably, that is a sign that their database is very small. They have when you ask them, is there progression? All the machine vendors are going to tell you, yes, we have progression. But how is the progression done? It is done only in the statistical manner, where in the small database, and they have tested the patients 2-3 times, calculated a standard deviation, and that's how they have done it. The standardization is not verifiable in this class of patients, and standard test strategies are there, but short test strategies are either not very good or they are not there at all. So if you are looking at a perimeter falling in this category, you should probably take opinions of maybe 2 or 3 people who are using that machine to know how good is their short test strategy and how good. So the class 1 perimeters are the ones which I mentioned in the first group, are mainly the Humphrey Zeiss and the Octopus. And the class 2 perimeters, they have got many, but in India, the most common are the Appaswamy, the Medmont, the Kova, and there are now many Chinese models also available. It is difficult to know all the names also, but there are many which have come into the market. So you have now the third class, which are not third class, but the class 3, which are the new perimeters, which are virtual reality based. So it just doesn't have a machine. It just has a wear-on thing which you put onto your eye and it is linked to a smartphone. So these are the third kind of things available. What are the questions you are going to ask your vendor when you want to buy? Test algorithms, what are being used? The database I already mentioned, software for progression I mentioned, time for the standard test I mentioned, and whether the short test duration programs are available, and technology to improve reliability, what kind of things are there. The Zeiss perimeter, which is very popular, is a bold perimeter. The thing is, it requires very important point, which I would like to point out to everybody. It requires regular service and calibration. Usually needs a correction lens in the form of a wide aperture lens. The new model which has come out, HFA3, has an inbuilt crystal lens. Now you need a specific room and low illumination is definitely preferable. Very necessary to have a service contract with that company, otherwise you will not be able to run this perimeter. The HFA3, the new one, has got some new advances, auto pupil size, head tracking, the CETA Faster, which is CETA Faster 2C, 24-2C, which is really giving very, very short duration, liquid lens technology where you don't need to put in an extra trial lens, and the real eye, which takes the image when the presentation of the stimulus and it checks fixation and the suspect area being tested. And it has a custom kinetic technology as well. The Octopus, on the other hand, is a projection perimeter, does not require a critical trial lens. Calibration is less critical. It auto-calibrates and it can be done in normal light. And progression, it has got this polar plots, which is a structure function correlation, which nothing like that exists in Zeiss. And it has newer technology, pulsar, for early diagnosis of glaucoma. So if you compare the Zeiss and the Octopus, this is a bowl, this is a projection. This needs very close maintenance, much less maintenance here. Trial lens is required in all the other models. Only in the liquid lens crystal model of HFA3, it is not required. Here, no trial lens is required. It does not have any structure correlation index. In the Octopus, you have the polar coordinates, which gives you structure correlation to your functional perimetry. And most often, if you go for glaucoma talks, most glaucoma talks and RCTs use the Humphrey, and less commonly the Octopus is being used by glaucoma specialists. That does not say that it is not good for glaucoma. Also, the administrator would like to know if you need a separate room. Definitely, it is indicated to have a separate room because visual field test is a subjective test and patient needs to be calm and not disturbed. So if you have a separate room, it is definitely better. And then you want to decide finally in conclusion, first know your aim. Do you want to have a VFA machine only to identify disease and complete the list of equipment available to you, or you really want to go into the nitty-gritties and manage glaucoma in a scientific manner? And then know your budget, not only the initial budget but also your maintenance budget. As I mentioned, there is a difference. To scientifically manage glaucoma clinic, you require a class 1 just to detect disease. Even a class 2 or a VR based perimeters, which have been doing very well, are good enough. Thank you very much.